So next topic is going to be on acromioclavicular joint, AC joint injuries. It's interesting because this is the whole symposium is evidence-based, and in reviewing the literature on AC joint injuries, there's not a lot of really good evidence-based medicine per se. There's good kind of prospective evaluations and retrospective studies, outcomes things, but there's not not a lot of good level 1 and level 2 evidence in terms of guiding how we manage these types of injuries. So a lot of you won't see as much of the literature review as much as how we actually manage them. So I have no disclosures, obviously, and in terms of the clinical questions, I mean, I think I'm starting to get to the point where I've been in practice long enough that I can see things start to come around in full circle. So, when I first started in training, there was a lot of talk about fixing AC joint sprains in specific athletes. Then there was some good data that kind of steered us away from it. And now, again, as people are maybe there's a lot of different reasons, but I'm starting to see a resurgence in indications for surgery for the AC joint. And we'll go over some of that stuff. And so we kind of try to answer the question: is are there some good hardcore, hard and fast surgical indications for AC joint injuries? And then, I think the most controversy we see is in that high-level throwing athlete. So if you have a pitcher or a quarterback who sustains a grade 3 AC sprain, what are you going to do with that patient? And so maybe we can answer that. So, typically when the common term patients come in, they say they hear patients either dislocated their shoulder or separated their shoulder. The AC joint is the shoulder separation. That's what I try to make clear to them. When the baseball player runs to the outfield wall, when the quarterback goes down, when you fall off your bicycle, when you fall skiing, and say you have a shoulder separation, it means it's an injury to the AC joint. And that helps me because when I'm taking my history in the office, some people will come in and say, I think I dislocated my shoulder. It's really their AC joint. It means two different things. So getting the terminology right is appropriate. We went over this anatomically, but again, just to review our anatomy, the ligaments of the AC joint are again, it's the same thing. They're not distinct ligaments per se as much as they are thickened portions of the AC joint capsule. And they're really going to control the relationship of the clavicle to the acromion from an anterior to posterior direction. Whoops, sorry about that. But what controls the rotation of the clavicle, what it looks like clinically riding high or in the superior-inferior direction, is the coracoacromial ligaments, the trapezoid and the conoid ligaments. And so these are much more thick ligaments, and this is really what we pay attention to. You'll see these have the impact on grade 3 AC injuries. So most of the times the injury occurs it's a direct force to the lateral aspect of the shoulder. You fall into the lateral aspect of the arm with an adducted shoulder. That's why cyclists get these injuries so much, because they're taught to tuck as they fall and they land on the side of their shoulder. They either break their clavicle or they dislocate their AC joint. I certainly see in more than enough sports where athletes fall to the ground, and it's really a continuum of injury. And so it starts off, in low energy injuries, the AC ligaments and capsule are going to be disrupted. Then if a higher energy injury, you're going to injure the conoid and trapezoid ligaments. And then the final tissue that's damaged is a deltotrapezial fascia. So your clavicle is really subcutaneous, but it almost feels like it's subcutaneous, but your deltotrapezial fascia, which is very thick and stout and strong over the top of the clavicle, is a main stabilizer to helping hold the clavicle down. I just want to go back one slide for 1 second. Just go back. Whoops. There we go. So, again, you have your deltotrapezial fascia coming over the top, and that's really an important stabilizer in terms of pressing this down. But when these ligaments are disrupted in a grade 3, again, patients and even clinicians will say, well, your clavicle is popped up, but that's not really the case, because as Dr. Leddy pointed out about the anatomy of the sternoclavicular joint, it's pretty relatively stiff and rigid, and what really happens is the scapula rotates downwards, right? So the clavicle pretty much stays where it belongs. It's the weight of the arm and the scapula rotating downwards. So the acromion actually goes inferiorly, and the clavicle stays where it is, but it looks clinically like it's popped up high. So physical examination, I think it's depending on what you're doing. If you're in the middle of a football game, you're going to you can reach up under the shoulder pads and palpate, but ideally you want to follow the same pattern every time you examine somebody. Inspect for deformity. You want to see how, is there a deformity at the level of the AC joint? Does it look normal? Is there swelling? And then you want to palpate, and primarily you're going to palpate the superior border of the AC joint, and you can actually palpate a little bit of a step off. You can grab the distal end of the clavicle, move it anterior to posterior, and then we're also going to look at how the relationship of superior to inferior. And reducibility is an issue I'll talk about in just a minute, because that's an important physical exam finding in terms of determining how we're going to manage these. A lot of patients who have low-grade AC sprains, you're not really sure they're going to have pain with a cross-arm maneuver. You just bring their arm across their chest, and they complain of pain at the level of the AC joint. So, to me, when I'm trying to determine, and the talk about surgery will focus a lot on this, is this a type 3 or a type 5 AC joint sprain? And the difference between the two is a type 3 is a disruption of the AC ligaments, the CC ligaments, and the clavicle penetrates the deltotrapezial fascia. So I think most of us in this room can tell that this clavicle is through the deltotrapezial fascia, because it looks like the clavicle is about to come out through the skin, right? You can just press on it, you can actually feel the bone. This happens to be a female patient with relatively thin skin, and I know that that's a type 5 AC dislocation. So the clavicle has penetrated the deltotrapezial fascia, and if I wanted to try to reduce that, what I could do is put my one hand on top of the clavicle, grab her elbow and push upwards and see if I can reduce that to where you can't actually see the deformity anymore. In a type 5, where it's gone through the fascia, the likelihood of you bringing that back to an anatomic position is almost zero. It's not going to go back. You'll just feel kind of like that there's something in the way, and that's what it is. It's not so much the Chinese finger trap thing, but just there's soft tissue interposition that gets in the way. So in a patient like this, that's easy. But when we look at this patient, a male patient, a little bit more muscular, it's a little bit more difficult to tell by palpation whether this clavicle is subcutaneous, in other words, has it gone through the deltotrapezial fascia or not. And in the early going, especially with the swelling that occurs acutely, it may be difficult to really make that palpation sense. But if you try the reduction maneuver, where you, again, press down on the clavicle, lift up on the elbow, you can actually feel the joint reduce, and you'll feel a little click or feel it snap. As soon as you let go of the elbow, it's going to drop right back down and go into that dislocated position. It's not going to stay stable. Now, just on an aside, an old historic treatment for these type 3 injuries was a brace called a Kenny Howard brace, and I don't know if anybody has ever seen one of those, but it was a brace that actually strapped your forearm over the top of your shoulder and squeezed it down and actually could reduce the joint. I remember in training, Dr. Bergfeld told me about that, and I was like, well, nobody would ever wear that, and he was like, yeah, people take it off. But ironically, I saw a patient early in my practice who went to Mexico and was treated with an AC dislocation. I had x-rays, showed a type 3. He was put into Kenny Howard. It was reduced anatomically. He came to my office. I said, if you don't take this off, it might heal. The whole thing healed anatomically. He had an anatomic restoration of his AC joint. That's the only case I've ever seen of that. I don't even know where I would get a Kenny Howard brace, but they have them in Mexico, so there you go. As far as radiographic evaluation, really all you need is an x-ray. There's almost no reason to ever go on to MRI for an AC joint injury. These are relatively straightforward. You need a standard AP view. Usually trauma series will pick up an x-ray view. The reason being, as you'll see with some of the high-level dislocations, there can be anterior to posterior dislocation or subluxation of the clavicle on the acromion. And then the Zenka view, which is really the best view of your AC joint, is shot with a 10-degree cephalad view. Now, historically, there used to be weighted views where you'd hang weights from the arms. There's a lot of kind of randomized studies that show that they really don't make a difference, and they really have almost no impact on patient management. So I never order a weighted view. I don't know too many orthopedic surgeons who would ever order one. I've seen a few ordered, coming from the emergency rooms, which really doesn't make a lot of sense because they're not going to determine what the ultimate treatment is going to be. When you're looking at x-rays, the one difference, we can look at some numbers. The average space between the inferior border of the clavicle and the superior border of the coracoid process is around 1.1 to 1.3 centimeters. So if you're trying to determine whether the CC ligaments have been disrupted, that number is something that you can kind of hang your hat on. But really, the better way to do it is to do, if you're going to look at the evaluation of the distance, look at the contralateral shoulder. So a lot of times you'll see x-rays for AC joint injuries or clavicle injuries done across both shoulders, so you compare side to side. There's a good point here is don't forget the coracoid, right? Let's say your CC interval, the distance between the clavicle and the coracoid, looks normal, but there's something disrupted about the joint. Where's that disruption coming from? There can be a coracoid fracture. Again, if we go back just a couple slides, you can kind of see your coracoid sticking out here, but you can have fractures of the coracoid as opposed to disruption of the ligaments themselves, although they're not that common. So we look at the classification of AC joint sprains, and this is important because a lot of our treatment is determined based on the level or the classification of the injury. So a type 1 sprain is really going to be a stretch of the ligaments without disruption of only the AC joint capsule. A type 2, which is just a higher grade type 1, the ligaments, it's like the same thing as a grade 1 and a grade 2 MCL sprain. How much did the ligaments stretch out? So these two I kind of lump together, because what the difference is as we move to type 3 is that not only did we disrupt the AC ligaments, but we disrupted the CC ligaments, the conoid and trapezoid. Again, this is the ligament disruption that allows the scapula to rotate downwards and see this joint, the AC joint, kind of displace more than 100% sometimes. In a type 4 dislocation, this is where you get a posterior translation of the clavicle on the acromion. I've only seen a very small number of these. Type 5, this is the one where now the clavicle is much higher. It's the same ligamentous disruption, but now your clavicle has penetrated the deltotrapezial fascia and it's in a subcutaneous position. And this I've only heard of. I've never met an orthopedic surgeon who's ever seen one. Has anybody ever seen a type 6? Because I haven't, and I've never heard of it. But this is where the clavicle goes inferiorly. So here you can see the clavicle is weighed down by the anterior aspect of the glenohumeral joint. So the treatment. So type 1 and type 2s, we see these all the time. Kids come in, they fall on their arm, they're sore in the AC joint, you press, they're not really high riding, there's a little localized swelling there, and you say, it's a shoulder separation, what are you going to do for them? Well, number one, it's non-surgical treatment. There's no indications for surgery at all in the acute phase of the injury. The sling is really for comfort only. These really do hurt. I mean, the kids are in a lot of pain. They almost can't rest. And what does the sling do? Well, the sling lifts up their arm. It takes the weight of the arm off of the AC joint. So for comfort only, they need a sling. Now, most of if it's an athlete, their question is, well, when can I get back? Well, it's a good idea to rest an inner joint, even for a couple of days. Kind of let things settle down. Then you can start them on passive range of motion, then active range of motion, and then strengthening exercises. And when can you let them go back and play? You get them back and play when they can protect themselves, when they have good range of motion and they have good strength and they're not out there. If they take another hit to the injury, it's just going to the joint. It's just going to hurt again for another couple of weeks. But they're not really going to do anything bad, so they can even play symptomatic. And at a higher level, these guys are going to want to play. The coaches are going to want to play. You're going to shoot them with lidocaine or marcaine before the game, have them have no pain during the game, and then they'll be sore as heck when the game is over. All that does is prolong their symptomatology because they just keep dinging it and dinging it, dinging it. You want to try to get it better because they can hurt. As far as osteolysis is concerned, you hear about that in weightlifters. I don't see too much post-traumatic osteolysis. What I've seen in the younger population, I've had a handful of high school kids who have sustained grade 1 and grade 2s, and they've gone back early, and they get almost like a heterotopic ossification, like an ossification of the AC joint capsule. They come back 8 weeks later, say, wait, my shoulder still hurts, you take another x-ray, and they have a bunch of callus around the capsule and the end of the clavicle. And I've had 2 cases where we've actually gone in and excised that heterotopic bone just because it stayed painful for more than a year, which is, I really never expected that to happen, but I've had to deal with it. But the question is, so you say to them, well, this is going to get better and you're going to be fine. Is that really the case? It's not really the case. If you look at the long-term follow-up, as you've heard before, one of the worst things for your outcomes is long-term follow-up. So now you have this guy who sustained, has had a couple of AC sprains throughout his entire career, and now he can't bench press, right? Every time he bench presses, he has AC pain. Every time he takes a hit, it hurts. And this is Dr. Bergfeld in the Naval Academy. So type 1 and type 2s, almost 40% of the patients will have mild symptoms, and a quarter of the patients with type 2 had severe symptoms. And these symptoms are pain with activities. A lot of it has to do with weight training. So what happens in these patients is that, even though they recover from the injury, their joint isn't normal and it has long-term sequelae. This is a more recent study out of Shoulder and Elbow, 2003. Again, 33 patients who had grade 1, grade 2 AC dislocations. 27% of them, a fourth of them, went on to surgical intervention by the end of the 2-year follow-up. And what's the surgical intervention? It's almost always a distal clavicle excision. We'll talk about that. Some of them did, you had 21% had a good or excellent results, but a good number had fair to poor outcomes. Again, mostly pain with cross-arm maneuvers, and I think the major difficulty is weightlifting problems. So you see a very high percentage with the radiographic changes. In my practice, where I start to see middle-aged people, you take x-rays of their shoulder for rotator cuff tendonitis or whatever the case may be, and at least a third of the men have AC joint arthritis. If they've played football or hockey or any other form of a contact sport, you see degenerative changes in the AC joint, and it's almost always related to old AC sprains when they're young. It's almost always asymptomatic, but there's a lot of radiographic sequelae to that. So, sorry about that. So again, in this study, 48% of the patients had an inadequate outcome with what we would consider a relatively trivial injury. So the treatment, arthroscopic or distal clavicle excision, is highly successful. If the patients are symptomatic, you just tell them, look, you get enough of this. A lot of times I'll tell them, we can probably burn this out with cortisone injections. You give them a cortisone injection, they get better, they stay better for 6 weeks, 8 weeks, 3 months, they come back, they're symptomatic, give them another one. And over a year or so, sometimes the pain finally goes away after the 3rd or 4th injection. There's really no harm in that. But if they're not getting better, or you just need to kind of move along, you can do a distal clavicle excision. Generally, you take off the distal anywhere from 5 to 7 millimeters of the clavicle. It opens up the joint space, it fills in with fibrous tissue, and they're generally asymptomatic. And this is, again, not a lot of good data on this, but this is a follow-up study showing that open versus arthroscopic is the same. There's an arthroscopic resection of distal clavicle is a little bit of triumph of the technology over ease. You make 2 little arthroscopy portals versus a small incision. They both do just as well. So it's just really dealer's choice. But then what about type 3 AC sprains? Because they're the ones that we really struggle with the most in terms, that's where the controversy exists. So if you have a pitcher or somebody who has a type 3 AC joint sprain in their throwing shoulder, the concern is are their shoulder mechanics going to be affected to the point where they can't throw? Well, I think most people who manage these, and again, this is kind of older literature, and there hasn't been anything that new that's refuted this, although we're seeing more move towards surgical treatment of type 3s. Again, this is Taboni's article out of Curlin Job. We had 20 high-level high school pitchers that he followed for 2 years after a grade 3 AC dislocation. Patients had good strength, no symptoms, pitched at a high level. So I think that's why the pendulum swung to the point where almost all throwers were being treated non-operatively. Again, this is a more recent study. These were not overhead athletes, but again, the patients with grade 3 sprains functioned very well, but if you notice, they had symptoms with a weaker bench press because the compression of the AC joint, that type of bench press activity is difficulty. And that's what I see in my clinical practice. The problem is really not the pain at the AC joint, but some interference with activities where strength training is required. That's a bad slide. So then we get to the higher level injuries, again, where the distal clavicle penetrates the deltoid trapezial fascia. I'm going to focus on type 5s because I said the 4s and the 6s I haven't seen any in my practice. The higher level injuries, you do have to worry about associated injuries, but that just gets picked up by good physical examination, and typically it's operative management for the type 5s. So if I see somebody with a type 5 and I tell them, well, this is something that requires surgery, they say, well, can we treat it non-operatively? You can treat it non-operatively, but odds are they're not going to do well just because they have pain because of the clavicle being through the fascia. So this is a study, again, this is a randomized prospective study showing that the outcomes of getting to the dislocation earlier is better than the outcomes of late. So 90% of the patients treated with early reduction and internal fixation did better than the long-term, the late reductions. And then you find that with some of the older surgical procedures, and this is an older article, when you repair the AC joint, do an AC joint reconstruction, I will tell my patients that odds are, even though I'll reduce it anatomically initially, it will displace a little bit, but that's okay. But you see that the prominent AC joint is more common in the patients treated later. That probably has to do with the fact that since the clavicle sits through the deltotrapezial fascia for so long, the quality of that tissue is compromised and doesn't provide as good as a support to hold it downwards. And the same thing on your x-ray follow-up. So the old operation that kind of was the workhorse for this was called a Weaver-Dunn. And basically what we did, we took the coracoacromial ligament, that little thin band of ligament that comes off the coracoid and attaches the chromium, and swing that over onto the distal clavicle, and that kind of was like a reconstruction of the conoid and the trapezoid ligaments. So this was your initial Weaver-Dunn. In the operation, we take off the end of the clavicle, take the coracoacromial ligament, which is relatively thin, and put it into the end of the clavicle, and that would hold it down. The problem with that is that ligament is not really very strong, and certainly not as strong as the conoid and trapezoid ligament. So before the advent of some other soft tissue techniques, surgeons were using Merceline tape or even metal wires to kind of wrap around the coracoid and go through the clavicle and pull it down. What's happened in the modifications is instead of using a synthetic material, we're now either using autografts. You can take a semitendinosus autograft from the knee or an allograft and do a soft tissue reconstruction. Again, wrapping the allograft or the soft tissue graft around the base of the coracoid and through the clavicle. And what's kind of come out in the more recent literature is making this more anatomic, because one of the issues, if you look at this, is that the coracoacromial ligament comes off the anterior tip of the coracoid process, whereas the conoid and trapezoids come more off the base. So by doing these anatomic reconstructions around the base of the coracoid, you hold your clavicle in a more appropriate position from anterior to posterior as well as superior to inferior. So this is just this was another randomized prospective study, semi-T versus modified Weaver-Dunn, and had better outcomes with the more anatomic and stronger graft reconstructions. Then there's been other modifications that talked about more anatomic reconstruction, so as opposed to just putting a loop around the clavicle, now trying to reconstruct both the trapezoid and the conoid, which attach in a more broad base. So you're seeing more drill holes put through the clavicle. There's this thing called the tightrope, which is just a synthetic tissue that you can do arthroscopically through drill holes. Some people in the Weaver-Dunn, I always take off the distal clavicle because I figure the joint is going to subluxate a little bit after healing, and if you have an unreduced joint, they're going to get some AC joint symptoms. So why not just take off the distal end of the clavicle? Well, there is a reason to not take it off. If you restore it anatomically, it adds stability to your reconstruction. So some surgeons will advocate not taking off the distal end of the clavicle. My attitude is, well, look, I don't want to have to come back and take off the distal end if they have symptoms later on. So I take it off every time, and I really haven't had any trouble with it. But most patients do very well with the operation. Probably one of the keys is, as our fixation techniques have gotten better, is to not over-reduce it. You want to bring the clavicle down to the acromion, but you don't want to certainly make it so tight that you reduce that CC distance, and that's important. So these are just, again, this is just one schematic of how you can do an anatomic reconstruction. Now they're doing some arthroscopically assist that are open, but I always will wrap around the base of the coracoid process and then come out through the clavicle, either through one drill hole or two. So this is a synthetic suture material, small drill hole in the clavicle, small drill hole in the coracoid, and you can tighten this rope down. This is the tightrope technique, and it pulls it down and reduces your AC joint. So here's one of our star football players who decided to go to New York and have this operation done, and had the drill hole put through the coracoid. Everything was going well till he took his first hit and then broke his coracoid process right through the drill hole. So no matter what you do, nothing's without consequence. It's a less invasive procedure, but then again, in a contact athlete, maybe making a drill hole is a stress riser. I'm not saying it's a reason not to do this particular procedure, but you need to realize everything has its pros and cons. So distal clavicle excision, we talked about that. It's going to have an effect. If you leave it there, it could have an effect on post-op symptoms of AC joint, but it does increase the stability of your CC reconstruction. So it's really a surgeon's choice, and again, there's no really good data there's no randomized prospective study on a CC ligament reconstruction with and without distal clavicle excision. And unless that's a multi-center trial because of the volume of the operations, I don't see any really good data coming out in the near future on that. So I think from a standpoint of summary in our clinical questions, number one, in my mind, my type 1, type 2, and type 3 AC sprains are going to be treated non-operatively in almost all cases. I probably will err on the side of taking an athlete who has a type 3 and saying, let's see how things play out, because I think I can get a good reconstruction done if the type 3 becomes symptomatic, because I know their deltotrapezial fascia is intact. I'll have a good quality tissue to do a nice reconstruction. And that's the case in even in the high-level throwing athlete. But if I have something where it's a high-energy injury like a type 4 or type 5, I'm going to try to convince them to move to early surgical intervention, because I think the outcomes are better, and that's what the data shows. So thanks. Any questions? If you I'm going to ask a question. If you see a football player with an AC sprain, how quickly are you going to tell them they can go back? Anyone who manages like high school football, Rob, what are you going to tell them? Right. So what's your average time? If they're going to ask you, how many games am I going to miss? That's it. You don't give them any predictions, huh? Okay. I think I tend to tell them they're going to be out longer than they think, probably because in the high school population, it's unlikely that I'm going to inject them with lidocaine to get them in a game. At the college level, it's a different story. There's a little more pressure to get them back in, and injections are used more freely.
I found a test for return to play, just that kind of cross-arm test. If they can keep their elbow up with resistance, then they're probably going to be all right when they go back and function. If they can't keep their elbow up with resistance, doesn't matter how much padding you're putting over their AC joint, they're still going to have function disability when they go back to play.
Yeah, that's a good point. I don't know how much we always try to pad them and stuff, but I don't know how much that really helps.